Thank you very much. It's indeed a great pleasure and privilege for me to be invited to share my view on E-antigen-negative hepatitis, chronic hepatitis B, about the nuke therapy. In 35 years ago, the majority of chronic hepatitis B were E-antigen positive. At least in Taiwan, at least two-thirds of the chronic hepatitis B visiting hospital clinic were E-antigen positive. Then after that, we have universal vaccination, we have long-term follow-up, so we know that there are very few new chronic hepatitis B, therefore very few new E-antigen positive patients since late 1980s. And spontaneous E seroconversion may occur over time. Then since 1990, we have therapy-related E seroconversion. And Nature history study also show that E-antigen negative chronic hepatitis B may develop after E-antigen seroconversion, particularly in patients seroconverted over age 40. So the landscape of chronic hepatitis B changed a lot. Professor Locke published a paper in 2002 indicating that E-antigen negative hepatitis is primarily in Southern European countries. They have a median of 33% E negative. In Asia, only 15, I mean the medium. And US and other Euro countries also 14%. But by recent correction of more than 1,000 patients who were came for the first time, eligible for the first course of therapy. Now it's almost 72% are E-antigen negative. Compared to the same center, biopsy confirmed chronic hepatitis B, 44% in 1987. So 30 years ago, increased from 44% to 72%. And the age, you can see very obvious difference. The mean age in 1980s is only 34, for the E-antigen negative patients, but now it's 59 years old, median. And 95% of our patients in these 3 years were treated with they choose entecavir or tenofovir therapy. Nuke therapy has many advantages, but the limitation is they can suppress duplication, but not cccDNA. Therefore, usually if cccDNA remains, you stop treatment, virus may rebound. So therefore, TASL-AASLD and EASL has recommended to continue nuke therapy for lifelong, long-term or even lifelong or until surface antigen loss. And only APASL guidelines, because we cover a large number of poor countries. So we consider the cost, consider the mutation, drug resistance issues. We recommended you can consider to stop treatment early in year 2000. In the three versions prior to 2005, we said the optimal duration is unknown, but decision to stop should consider clinical response and severity of the underlying liver diseases. No doubt, the cost will increase if you continue treatment. This is a very recent publication from Korea. You can see in these years, there is a 15 times increase of medical cost, majorly due to the drug. So since the availability of entecavir and tenofovir, the cost increased even faster, despite the liver death actually has decreased. Therefore, that means late stage or advanced liver cirrhosis and SCC has been decreased. So the cost for this severe liver disease must be decreased. So even though the cost is increased to a level that many resource-limited countries cannot afford. Besides drug resistance, which is no more a concern now, and the cost, there are other concerns related to human nature, such as willingness to receive lifelong therapy. A study in Singapore, a rich country, even a rich country, a survey shows that only 44% of the patients willing to receive lifelong therapy if drug is free. But if you have to pay $10 per day, only 25% of the patients willing to receive lifelong therapy. For the real-world studies in Hong Kong, also a rich region, 7-year entecavir therapy in 200 patients, 22% unwilling or had financial difficulty to continue therapy. And another study involving more than 600 patients for 5-year entecavir. 83% of them are Asians. 7% of them self-stop or lost to follow-up. This is very serious because loss to follow-up means no monitoring after stopping treatment. So the patients may encounter severe relapse and even to a fatal hepatitis failure, like this reported early into 2002 by Dr. Lim. Then is the issues of adherence, which was first reported by Professor Locke in 2011. After that, adherence issue has attracted much attention. A review and a meta-analysis in 2018 shows that 75% or more than 20,000 patients had poor adherence, had good adherence. That means 25% are non-adherent. A modeling study shows that adherence down to 65% would lead to 2.6 million additional deaths in 15 years. And a most recent real-world study shows that 30% of the patients had poor adherence. That means less than 90% adherence. And 10% of them, 11% of them have less than 70% adherence. So these poor adherence, patients with poor adherence increase the risk of SCC and cirrhotic complication for 3/4. And for the liver mortality increase 16-fold in cirrhotic patients and at a dose-dependent manner. So this is a very, I think the rate is too high, but this is published, the result. So because of the concerns of cost and drug resistance, again, Professor Locke's team reported a small study, 2-year lamivudine therapy with HBV DNA undetectable 3 occasions, each greater than 3 months apart. The relapse rate on 1 year, relapse rate is 50%. And then the follow-up subsequent 2 small studies from Asia also show the relapse rate around 50%. And they are all of the relapses has no serious complication. Based on this, Asian studies, APOSO Working Party decided to recommend a stopping rule. that is undetectable HBV DNA on 3 occasions, 6 months, at least 6 months, each 6 months apart. That is 1 year. Different from what used in Professor Locke's study is 1 year is similar to the 1 year consolidation after E antigen loss in E antigen positive patients. Then subsequent studies in Asia show that maybe longer treatment is needed. So in year 2012 guidelines, we added nuke therapy must be greater than 2 years and undetectable HBV DNA for 1 year. This is so-called APASL stopping rule. And when we recommend this stopping rule, we emphasize that monitoring is very important. So the schedule is ALT per month for 3 months, plus HBV DNA every 3 months for 1 year, then ALT HBV DNA every 3 to 6 months according to the disease severity. Once ALT is increasing or ALT level greater than 5 times normal, you have to follow, monitor ALT, bilirubin, INR every 1 to 2 weeks for the treatment decision. The Western countries started to look at the finite therapy issues. I believe it's after the publication of a pivotal study of Professor Hajianis in 2012. In only a small number of patients after Atefovir trial, they found an off-nuke surface antigen loss rate up to 39% in 5 years. And 2 systematic review with nearly 2,000 E-antigen-negative patients each, show that the virological relapse rate is about 60 to 70%, clinical relapse rate is about less than 50%, and treatment rate is less than 40%. And decompensation is very rare. Only one showed less than 1% in cirrhotic patients. One clearly indicates that it's 0.8% in cirrhotic patients. So it's generally said it's quite safe. So compared with the earlier guidelines, AASLD finally accepted finite therapy as an option. So in AA guidelines say decision to stop nuke therapy requires consideration of risk of virological relapse, decompensation, HCC test, financial burden, medication monitoring, adherence, resistance, etc., and patient and provider preference. Actually, these reasons are what we consider in APASL guidelines. ESO guideline also in 2017, discontinuation of nuke may be considered if HBV suppression greater than 3 years and guaranteed off-nuke monitoring. But these guidelines, although they accept as an option, but they are not including patients with pre-therapy, cirrhosis, and or hepatic decompensation. But actually, Asian study show that the incidence of hepatic decompensation and HCC after stopping nuke therapy actually were not higher than those continuing nuke therapy. The red circle is from our group. This is in the same study. Those stopping nuke therapy, 4% develop hepatic decompensation, but 6% in those who continue. And the other studies say almost at least not higher after stopping nuke therapy. Hepatocellular carcinoma, there are 2 matched controls study also show that at least the incidence of SCC after stopping nuke therapy not higher than those continuing therapy. So maybe AASLD and EASL should consider this data. The other most important reason is the optimal endpoint, surface antigen loss, is rarely achieved during nuke therapy. Here are 3 studies. The highest is from Korea, genotype C, more than 5,000 patients during 6-year entecavir therapy. Yearly surface antigen loss rate is only 0.33%. And for the tenofovir, 7-year tenofovir, only 0.3% in 7 years. And in our entecavir tenofovir cohort of more than 1,000 patients, the annual S loss rate is only 0.15%, very, very low. So after Hajiani's report of very high S antigen loss rate, the subsequent studies show consistently that stopping treatment, the S antigen loss rate is high, particularly in European studies, 39% to 16% in 1 year. But in Asian studies, actually Henry Chang was the first who reported increased surface antigen loss in 5-year lamivudine therapy. But he did not stress this point. He just said lower surface antigen level at end of treatment decrease the critical relapse rate. So there are major Asian patients only. In our group, more than 600 patients, 60-year cumulative surface antigen loss rate is only 16%. So maybe the age of infection or different genotype may explain this difference between Caucasian patient and Asian patients. But anyway, all studies of stopping treatment, including the small randomized control study, show that stopping treatment much increased surface antigen loss rate. Yes, end of treatment surface antigen level less than 100 is associated with much higher S antigen loss rate. 5-year, 33%, and for those greater than 500, only 3%. And during treatment, surface antigen decline greater than 1 log 10, end of treatment less than 100, and sustained response. Relapse not treated are predictors of S antigen loss. Other studies, including Henry Chang, also show that end of treatment surface antigen less than 100 units has a greater 10 times, more than 10 times increase of surface antigen compared to those greater than 100. If we divided the event after stopping treatment, we show that the patient with sustained response as the 60-year cumulative S antigen loss rate increased to 36%. For patients with virological relapse alone, 13%. For clinical relapse, of course, lower, but if the patients keep untreated, 19%. For the patients retreated, only 1%. So this is consistent with previous studies here. Non-retreated patients, this is first pointed out by Professor Hajiani, that non-retreatment is the strongest factor for S antigen loss in their study. But the number is small. In a large number study, 90% versus 1%. And Dr. Chen in Kaohsiung also showed 18% versus 0%. The hazard ratios increased to 18%, 18.6. So seems no doubt that you stop treatment, and those who develop clinical relapse, you keep untreated, they have increased the chance of S antigen loss. Now, there are immunological studies supporting that effective surface antigen specific CD8 T cells have help control the viruses, so that we can explain why you stop treatment and the patient has a higher rate of S antigen positive. So the very important point is, if a patient encounters clinical relapse, to treat or not to treat, because not to treat have a benefit of increased surface antigen positive rate. In not treat, safe, very safe, yeah, but patients can be controlled. So the general indication for retreatment is similar to that of treatment-naive patients in 3 major guidelines. That is DNA greater than 2,000, and ALT level greater than 2 times upper limb normal, and persistent for 3 months. You can consider treatment. But for patients with hepatitis flare is more complex, because hepatitis flare actually usually is the result of endogenous immune response, help to killing the hepatocyte. So in good size may followed by spontaneous remission, like spontaneous E-cell conversion. The poor side is they may deteriorate to become hepatic decompensation. So if patients had overt hepatic decompensation, no doubt you have to treat the patient as soon as possible. Some investigators suggest if a patient has a confirmed ALT elevation greater than 5 to 10 times upper limb normal, treat. Or patients with signs of impending deterioration like bilirubin greater than 2 milligram, or increase in INR, to treat. All these are question mark, we don't know. But according to our experience in natural history, we consider that patients with ALT elevation but surface antigen level is decreasing means very effective endogenous immune response. So such patients may not require retreatment, like that in the right panel. We consider this is a beneficial or good flare. For those flare with increasing surface antigen, that means that their immune clearance effort is ineffective. Such patients may need immediate treatment. For example, these patients, perhaps we should treat the patient here, because at this point, surface antigen is already increasing. So finally we have to treat them with nuke. So by this classification, we retrospectively to review our patients. For those with good flare, bad flare, we have more than 288 patients with ALT greater than 5 times upper limb normal. You can see the response is very good in terms of surface antigen decline. 1 year decline is greater than 1 log, and over 75% decline occurred in 69%. Professor Penn reported that greater than 75% decline in first year has increased chance of surface antigen decrease to less than 100, or increased surface antigen loss rate during 5-year entecavir therapy. So we think greater than 75% decline is an important predictors. So patients with good flare, but the patients already treated, you can see here, when they treat, the surface antigen already decrease. You treat them, surface antigen increase instead of decrease. Some of them. This occur in almost 40% of the patients. They have a rebound of surface antigen. Our speculation is they have a very strong immune response, but interrupted by too early nuke therapy. So this is for the consideration of Richard. So to summary, I think there is an emerging paradigm shift from indefinite, long-term, or lifelong therapy to finite nuke therapy because of these considerations and minimize the concerns. And more importantly, increase the surface antigen loss rate. And in addition, I think the high S antigen loss rate may serve as a benchmark for the new therapies or new strategies. For new therapies to be practical, they need to have a high surface antigen loss rate like this strategy. Now, but there are still things to be studied, such as the optimal timing to start, to stop, and to restart nuke therapy. The optimal duration of consolidation to minimize the relapse rate. And we need more study on pathological studies to understand the underlying mechanism. I just thanks my patients who trust me in the past 40 years and have a very good cooperation with me. Our co-authors, we have a superb supporting teams here, and the grant, endless grant from Changkyung Memorial Hospital. Thank you very much.